So hello, how are you today? Another great little case. This is a case of an upright 5, which I think without high magnification you would really struggle to clean shape and obturate effectively. So this case has got a few aspects to it, a few learning points. It's obviously a deep split. It's also a reverse engineered apical gauging technique. So usually what I'd do is I'd apically gauge the tooth before I took the x-ray and did all the shaping and things. But in this case, we found at the very last moment that the sort of the portal of exit, the end of the tooth in one of these canals was wider than usual. So this is kind of a problem solving tip here if you feel like your GP points are a little bit wider than usual. So anyway, let's get on with the case. So this is a case of an upright 5. The filling had been carried out by, I believe, another dentist or a hygiene therapist in the distal aspect of the tooth. And the patient, as always with these cases, the patient having no problems at all, the filling's done, and then they start to have symptoms and pain. And this is a really common thing we have with patients is, I had no problems. The dentist has gone in, they've done the filling, and vis-a-vis, it's all their fault. So that's a really difficult thing to manage, especially when you're referring dentists, when you're accepting referrals from other dentists, how to be kind of subtly explain those sorts of things. So I think with this case, I just said to the patient that's really common, and it is common, and also it's probably one of the most common risks associated with fillings. So for any general dentists out there, it's always good to sort of make the patient aware these things can happen, especially if say this patient had some bite wings and the general dentist was doing some fillings and it was quite deep. It's always good to kind of just be honest with the patients and sort of warn them in advance that this could sort of happen. So the patient came for a consultation. We talked about the risks and benefits, all very sort of just normal and bog standard and just run of the mill. Although my slight concern with this tooth was that there's a hell of a lot of canal space on the PA, but as we reach the end, it disappears. Okay, and this could be for a few reasons. This could be because it's calcified or sclerosed, or it could be a deep split. With the benefit of hindsight, obviously there's a deep split, but I wasn't too sure. Also, what this could be is this tooth could have a really quite acute bend in the end, and this could be just the orientation of the end of the tooth. So there's an argument to say, do you need a CBCT in this case? But I think particularly in this case, I think we've got high magnification. It's a large root. Let's just see how we get on. So first things first, we're just going to access the tooth. It's a nice filling. Whoever's done the filling's really nice. And I'm going to try and make the most conservative hole in this tooth as possible, because we want to obviously conserve tooth tissue. And as we can see, there's like kind of a dentine bridge that's been created here. And what you could do is you could use a fast handpiece in this case, but I think sometimes that can be a little bit too destructive and you can't really see where it is. So what I'm going to use here is I'm going to use an ultrasonic tip, and you'd be surprised how much energy these ultrasonic tips have, and that's just a really good way of just removing like a thin sort of dentine bridge, opening up the canal space here. And now what I'm doing is I'm irrigating and I'm activating and just getting rid of all them sort of pulpal remnants and all the sort of nastiness from the tooth. I don't usually activate the irrigant early on, but I just felt like there was a lot of stuff in the pulp chambers. And this is where I see the deep split straight away. To be honest, the video doesn't do it justice. In the microscope, it shows it pretty obvious. And you can see here that there's the buccal canal. And if we just sort of move our mirror very slightly over, there is the palatal canal. And I think if we look on the radiograph here, the deep split is just where the end of the canal disappears, and the green line here, this is where the end of the tooth is, and that's a significant sort of amount of space there to find with our hand files. A number one tip here is when you've got a deep split is you make quite an obtuse bend in a hand file, and then what you're going to do is you're going to take the bend and then you're going to rake it down one of the walls. In this case, I was going to go for the palatal canal, so I'm just raking the file down the palatal wall of this tooth, and then what this is going to do is the bend in the tooth is going to slip into the palatal aspect of this canal, and you'll notice that the buccal canal here is still open, and we've got the file successfully in the palatal canal, and then essentially we just gain the working length. This went to length pretty easy, so I was happy to push it straight to length. And now I've got the working length in the palatal. I'm going to do the same technique. I'm going to rake down the buccal wall with the file, and you can notice now that the file is in a different position, so it sits in a different position now, and we can see there that the palatal is still open, but the file is in the buccal canal, and then we're going to gain another working length. So we're getting on with this now, but what you'll notice with the buccal canal is that it was quite tight to get to length. So what I want to do here is I just want to get my size 10K file and just give it a little bit of watch winding and open up that canal prior to us going up with further diameter files. So we know the working length is 20, and I'm going to use a glide path file 15 HyFlex in the palatal canal just to open this up ready for our final shaping file. And then once we've used it in the palatal, we're going to use it. Sometimes it's quite difficult to use the HyFlex files in this case, especially the size 15, because the bend doesn't keep its shape. So you just got to use high magnification to get in there. And then it's the same protocol with the size 20 HyFlex. And again, I'm going to use this at the full working length. Again, controversial. It's a tough one, isn't it? And what I like to do is essentially use the master apical file minus 0.5 millimeters from the working length, and that accounts for the apical constriction. And we're going to use the final shaping file as a 3004. So you'll notice that the taper on this, or the sort of thickness of the file, is much smaller than, say, if we used to use a 25 variable. And this is mainly because what we're going to be using is we're going to be using 2 GP points in the same small hole. And now we're going to use these narrow tapered GP points 0.5 millimeters from the working length, because that's what we've shaped the file to, and then we're going to just place the 2 GP points, and again, I like to place them, feel for Tug-Back, snip the ends off. Not a lot of people like to snip the ends, but I like to snip the ends because it just shows me where I am when I fit them. And then we take the x-ray, and we look at this x-ray and we think to ourselves, is this x-ray too long? You know, it's a really difficult x-ray to look at here, because on the face of it looks wrong, but this might be the correct length. Okay, so in all these kind of situations, what I do is always just go straight to check the working length, and in this case now I'm going to check the working length, the size 15 K file. It's been known that these types of files are the best for gaining the correct working length, and if we take it out, I can confirm that it is definitely 20 millimeters. And then I'm going to recheck the GP point. So I'm going to get a GP point, fit it to 19.5, and then when I fit the GP point to length, I feel like that I can feel Tug-Back here, but actually when I let go of the GP point and then I sort of put a little bit of pressure down onto the GP point, it then sort of slips a little bit further, and that indicates that maybe the GP point is past the apical constriction on the end of the tooth. So you can see here that the GP point is at 20 millimeters. Now I know that is at the working length, but don't forget we have shaped our master apical file, our 3004 tooth saver file to 19.5. So I'm not happy that the apical diameter of my GP point is the same as what I've shaped it to. So to counteract this problem, we're going to just chop off the end of this 30 and make it into a 35. And I've got this gutter cutter here which cuts off the GP point to a 35. And then what we do is we set the GP to correct lurking length, which is 19.5 again. And I am going to very, very gently push this GP to length, and it sits very snugly at 19.5, and we've got a nice bit of Tug-Back there, and it looks really nice. And when we take the second cone fit radiograph, it looks again like it's not obvious if it's at the end of the tooth, but I think this PA is a much clearer PA. I think that it is at the working length, and we can see here I've sort of drawn where I think the palatal root is, and I'm happy that's at the working length. So I'm happy to start with the obturation. So what we're doing here now is we're doing our final irrigation protocol, sodium hypochlorite and EDTA, and then we're going to dry the canal with paper points. Okay. And then what I didn't show is I like to disinfect my GP, so we put them in this Style Italiano GP disinfector. And what I always like to do is I like to pick up the GP point first with my tweezers, put them to one side, and then I fill the canal space with one fill, and then I've got the GP point ready to go straight in there. And you can see now that I have obturated the two canals quite far down. The root canal is quite a significant amount of space there to fill up. And what I'm doing here is I am probably doing the cardinal sin of all obturation, is I'm doing using a backfill when I have used a bioceramic in the palatal. Now, I think I was fully aware of what I was doing at this point. By the way, I hadn't completely forgotten. I think the bioceramic is occupying a certain space in one part of the root canal, and the backfill is occupying a different space. So I'm not worried that the bioceramic is going to be denatured by the heat from this. And also, I've got to ask myself, how am I to fill this space adequately with a normal restorative material? It's just too far down, way too far down, even for a self-etch bond. So that's my rationale between the reason why I've used this one gutter burger. And we look at the final X-ray, and I would say to the untrained eye, this doesn't look great, but to the trained eye, this looks absolutely fantastic, because what you can see here is this kind of like sort of explosion of sealer into all the little nooks and crannies. So we've got quite a large sort of distal sealer puff on the tooth. We've got a nice little sealer puff on the mesial aspect, and then we've got the two portals exit. So in my mind, I think this looks really, really, really nice personally. I'm very, very happy with this. And to finish this off now, I am just redoing the filling. And overall, again, another week, another fantastic case. If you have any questions, if you have any suggestions, or if you have any criticisms of this case, you feel like you could have done something a bit different, please comment in the comment section below. I answer all your questions. If you're interested, we've got a membership program. The membership program gives you exclusive access to content that isn't readily available publicly. And I will see you all next week for the next video. Okay, bye bye.